Hi, everyone. I'm going to give a couple minutes for everybody to be able to get into the webinar. So sit tight. We'll get started in just a couple minutes. Great. All right. Well, good evening, everyone. Thank you for being here for tonight Mind Matters webinar, Suicide Risk During Pregnancy and the Postpartum Period. My name is Amy Schrader, and I will be your moderator for tonight's talk. We have a meaningful and rich seminar prepared for you on this important topic that brings together expert perspectives alongside a personal story. We will talk about topics such as interpersonal violence, mental illness, suicidal thoughts and actions, and death during tonight's seminar. Please take care while listening. We will provide resources for perinatal mental health support at the end of the presentation, and we encourage anyone to use these and to share them with their family and communities. Please submit your questions during the presentations through Zoom's Q&A feature. We've set aside time at the end to go through your questions. In recognition of September as Suicide Prevention Awareness Month, Michigan Medicine has put together this webinar as part of a larger series to address important topics related to suicidality. Mental health conditions that affect people during pregnancy or postpartum, known as perinatal mental health conditions, happen during the year before and after delivery, a long period of time to consider. In the US, approximately 22 maternal deaths occur for every 100,000 births each year, with up to 20% of these maternal deaths due to suicide. This means that maternal suicide deaths are more common than deaths caused by hemorrhage or hypertensive disorders. The 2022 CDC report on pregnancy-related maternal mortality showed that mental health conditions are the leading underlying cause of pregnancy-related deaths. And perinatal suicide is a complex and devastating public health issue with far-reaching consequences for individuals, families, and communities. To address this crisis, everyone should try to better understand suicide risk factors and effective suicide prevention strategies. By openly discussing perinatal suicide, we can break down stigma, raise awareness, and support those who are struggling with perinatal mental health concerns. So we will be doing just that. Perinatal mental health stands at the critical intersection of public health, data and policy, clinical experience, and patient experience. Public health plays a vital role in understanding the prevalence, risk factors, and prevention strategies for perinatal mental health conditions. And to give us this population-level overview, today we have Dr. Brianna Mezek joining us. Dr. Mezek is a professor of epidemiology at U of M, serves as the director of the Master's of Studies program in epidemiology, and as co-director of the Center for Social Epidemiology and Population Health. Next, data and policy inform the development and implementation of effective mental health interventions and support systems. To develop effective prevention and intervention strategies, we must first understand the prevalence, risk factors, and outcomes related to perinatal mental health conditions. And data plays a pivotal role in informing public policy decisions in this area. Dr. Kara Zivin joins us today to give us this context. Dr. Zivin is the Marcia A. Valenstein, MD, Collegiate Professor of Psychiatry and Professor of Health Management and Policy at U of M, where she leads the Perinatal Mental Health Services and Policy Program. Dr. Zivin is also a research career scientist at the Ann Arbor VA. Clinical experience provides valuable insights into diagnosis, treatment, and management of perinatal mental health conditions. And Dr. Maria Music offers that perspective as a psychiatrist and professor in the departments of psychiatry and obstetrics and gynecology at U of M. She's also the co-director of Zero to Thrive, Women and Infant Mental Health Program, and medical director of both the Perinatal Psychiatry Service and the MC3 Perinatal Psychiatry Assessment Program. So Dr. Music will provide valuable insights into the diagnosis, treatment, and prevention of these conditions. She'll also share her expertise on the importance of early intervention and the role of healthcare providers, families, and communities in supporting the mental health of pregnant and postpartum people. Patient experience highlights the importance of patient-centered care and the impact of perinatal mental health on individuals, families, and communities. And today, we will delve into the personal journey of a patient who has bravely shared her experience navigating perinatal mental health challenges. Powerful story offers a unique perspective on the complexities of maternal mental health and the importance of early intervention, support systems, and the resiliency of the human spirit. So by listening to this firsthand account, we hope to gain a deeper understanding of the challenges faced by individuals experiencing perinatal mental health conditions. And this story will also serve as a reminder of the critical role that healthcare providers, support networks, data-informed policies, and society play in ensuring the well-being of pregnant and postpartum people. Each of these perspectives offer a fuller picture of this topic's scope and potential areas of hope. So we'll begin with the public health perspective, offered by Dr. Brianna Meza.
Thank you, Amy. You go to the next slide, please. So as Amy mentioned, in the United States, there are about 22 maternal deaths for every 100,000 live births. This sets the United States as unique as a developed economy for having a maternal mortality rate this high. And these deaths, as Amy mentioned, are sort of across the entire sort of period, both during pregnancy, birth, and then the majority, of course, or I shouldn't say of course, but the majority occurring after birth. And if you go to the next slide, please. The good news about that chart is that the CDC estimates that 80% of this maternal mortality is preventable. What the CDC means by preventable, and I want to call attention to this because I think it sort of points to the broader context in which tonight's webinar is taking place, is that it means that it could be avoided with changes to either the patient, so intervention that occurred at the patient level, the family level, the provider level, the facility level, the healthcare system level, or even the broader community. So what it means is that there's a lot of different ways that we could think about prevention and intervention. As Amy mentioned, approximately 1 in 5 of these maternal deaths, the majority of which is the largest proportion of that maternal mortality of preventable mortality is due to a mental health conditions, whether this is depression, anxiety, suicide, and related suicide, or substance use disorder. Next slide, please. So when it comes to actually understanding or getting clarity, I should say, as to how do we identify these points of potential prevention or engagement in suicide prevention during the perinatal period, it's important that we have a strong empirical or data-driven understanding of both the individual characteristics that are associated with suicide mortality during this period, as well as the circumstances, whether those are health circumstances, psychological, or social circumstances that are present in these lives, that the lives of people who die by suicide. That is, what are these broader set of factors that contribute? And the next slide, please, or next, collectively, knowing the answers to those questions will inform suicide prevention efforts, both for higher risk groups, but also for the general population of people. The next slide. So the difficulty in answering those questions is a need for data. And I know Dr. Zivin is going to talk a lot about the different types of data. And the data system that I'm going to be talking about today is focused on suicide mortality. And in 2003, the CDC, in an effort to kind of try to respond to the needs to have better data on suicide mortality more generally, launched this system they call the National Violent Death Reporting System. This is run by the states. We have a site here in Michigan, based in Lansing, that is intended to provide timely information to policymakers and practitioners about trends and characteristics in violent death. So it's not just suicide, but given that the majority of violent deaths in the United States are suicide deaths, it's been an incredibly important resource for researchers like myself. And then next slide. One of the things that makes this data a important resource is that in addition to the sort of standard information that is recorded on death certificates, which is not much, frankly, This data set includes information on what they call what the NVDRS calls contributing circumstances. So these are things that were happening in the person's life around the time of their death that are thought to have contributed in some way, shape, or form to the death. These are some of the things that I'm going to show you data on some of these characteristics, but they are more expansive than what I'm showing here. But these are sort of the main things that, based on prior work, we thought were going to be most relevant for understanding suicide during the perinatal period. Next slide, please. The other thing that makes this data set really unique and really important for understanding suicide during the perinatal period is that the NVDRS also has what it calls qualitative text narratives. These are literally paragraphs that are written by employees of this surveillance system that use all the information that they have, whether it's the medical examiner report or the police report or any other interviews with family or friends, for example, that is written with the goal of describing and contextualizing the salient circumstances in that person's life at the time of their death. And this allows us at a population level to not just get the numbers of suicide deaths, but also a little bit of insight into the story behind those numbers. The next slide, please. And so what I'd like to share with you tonight is some results from a recent study that we conducted using these data sets using this data that were trying to answer the following questions. We were trying to understand, how do the contributing circumstances differ between perinatal and non-perinatal women? I'm not going to spend a lot of time talking about that today. But more importantly, what I think was the unique insight of our study is we wanted to look at the circumstances comparing women who were postpartum to women who were currently pregnant at the time of their death. In addition, because of these qualitative narratives, we could also identify key themes in these narratives that were relevant or sort of more pronounced during these among these perinatal decedents, and that collectively we could use these to generate insights about points of engagement, hopefully for preventing perinatal suicide. Next slide. So our sample included 1,150 people. The majority of these people, consistent with that graph I showed you earlier, were in the postpartum period, and by that I mean 1 to 365 days postpartum. The sample is limited to people who are female and who are in the kind of reproductive age, which is defined as 10 to 50 years. Next slide, please. So again, one of the things we wanted to look at is comparing the sort of circumstances that were more pronounced, or if there were circumstances that were more pronounced among the decedents who were postpartum at the time of their death compared to people who were pregnant at the time of their death. And what we saw is that there were a few. So people who were postpartum at the time of their death were more likely to have circumstances related to depression or mood disorders, but also other mental health diagnoses, and where they were also more likely to have recently experienced bereavement, so death of a family or friend, compared to people who were currently pregnant at the time of their death. The next slide, please. The other thing we were able to do, again, because of this very unique data element in the NVDRS system, which are these qualitative text narratives, was to actually apply traditional qualitative and analytic techniques to understand the key themes that were in these, represented in these, again, the stories behind the number, or at least the stories that are accompanying the number. I want to call attention, there were 4 main themes that we pulled out. So these were intimate partner violence, intimate partner problem that could have included a history of a physical or verbal abuse, but it also could have included a recent breakup or a divorce, for example. So it didn't have to be, it was a full range of experiences. Also, mental health was a common theme. I want to call attention that another important, I think, insight of our paper was that there history of postpartum depression in a prior pregnancy. So this kind of helps us understand not just the pregnancy in which the person passed from suicide, but a history of postpartum depression, because that can help us really identify potential high-risk groups for very early intervention, right at the point of sort of at the point where she knows she's pregnant, for example, that would be an opportunity where we could start thinking about interventions or supports. Substance use, as I mentioned earlier, is a common is both a common cause of perinatal mortality, but is also comes along with things like suicide, which is we saw here. And then finally, perinatal loss. So I mentioned the death of a family member or friend, but also having experienced a miscarriage or experienced a stillborn death were also kind of common themes that we saw here. So to summarize, when we again, I won't emphasize that I didn't show you information on this first point, but I guess I'll call it out here just quickly, is that compared to women of similar age, race, ethnicity, educational attainment, and marital status who were not pregnant or in the postpartum, so sort of compared people who were not pregnant or recently pregnant, perinatal decedents were more likely to have intimate partner problems and depressed mood. And then among these perinatal decedents compared to those who were pregnant, those who were postpartum, so people who were in the postpartum period compared to people who were pregnant at the time of their death, were more likely to have mental health problems, including but not limited to depression, and were more likely to have experienced a recent bereavement. And then finally, the major themes that we saw in the narratives of these perinatal decedents really provided important additional context related to mental health concerns beyond depression. These included substance use, anxiety, insomnia, and even recent psychiatric hospitalization. The importance of relationships, including intimate partner problems, but also bereavement. And finally, the reverberating impacts of prior pregnancies, including a history of postpartum depression and pregnancy loss on subsequent risk of perinatal suicide. So thank you for the opportunity to share this with you.
Hi, and good evening. Thank you for being here. Dr. Mezek and I worked on that material that she just discussed along with many of our team members. I'm going to pivot now to talking about research that is another unique perspective because my team and I don't necessarily look at specific individuals in a clinic, but rather we're looking at larger data sets that can include information on thousands of birthing people across the United States. So for example, we can look at which diagnoses doctors document during these pregnancies and after birth, for example, anxiety and depression, and which healthcare services, for example, medication or therapy that birthing people use. Since these data sets are large and include many people, we can analyze demographic characteristics such as age, race, and ethnicity, and outcomes, for example, suicidal ideation and self-harm. We can then look at how these outcomes change over time. So for example, thinking about important policy changes, such as the Affordable Care Act, and we can look at trends. The next slide, please. So as part of our research, we often think about things that may get in the way of accessing care that people need. Unfortunately, most pregnant and postpartum people don't get the care that they need. This slide shows the many links in the chain to accessing treatment and getting better. So people who have symptoms must go through screening, diagnosis, and treatment to have a chance to recover. But unfortunately, many barriers can occur at each step. So in the interest of time, I'm not going to go through every single step here in detail, but here are a few examples. So people might not know that they can get insurance coverage through Medicaid. They may have a long wait to get access to an available mental health provider, or they simply may not be able to drive to the appointment. I'm sure that a number of you on this call have experienced some of these challenges when trying to navigate our complex healthcare system for mental health care or physical health care or both. Next slide, please. However, people still need quality health care, especially as more people experience suicidal ideation nationwide. So the main ways to treat perinatal mental health conditions include prescription medications and psychotherapy. But only half of the people with depression during pregnancy get a diagnosis from a healthcare provider, and less than 15% get treated. So thinking back to that cascade or staircase that we showed on the prior slide, it's important that healthcare providers, families, mental health and women's health organizations and policymakers all work together to increase screening for perinatal mental health conditions, make sure those people who have a screen positive get a diagnosis, and make sure that diagnosed individuals get the treatment they need. But so we ask, how do we make this happen? Next slide, please. So federal health policy represents one way that we can make big changes. So two federal policies that we've been studying that have had a big influence on perinatal mental health are the Mental Health Parity, Addiction, and Equity Act, or just called Mental Health Parity, and the Patient Protection and Affordable Care Act, also known as the ACA, or some people knew it as Obamacare. As many of you know, people in the United States get health insurance through a variety of different options. So one could be through private insurance through your employer, another could be Medicaid or Medicare, public insurance, and then some people don't have any insurance at all. And so these differences in insurance coverage means that some people may not get the health care that they need. So these two policies listed here aim to increase coverage for mental health conditions for more people. So our research works to assess how policies like these changes in access to cost, access and quality of care for people with perinatal mental health conditions and their families. Next slide, please. So one way to look at how policies impact people is by using maps. So maps can help tell a story about our lives across places. In the study I'm showing here, we looked at how many people received a diagnosis of a perinatal mental health condition and suicidality before and after the implementation of the Affordable Care Act, or ACA. We also looked at how many people got psychotherapy before and after the ACA. So in this study, we were looking solely at private insurance, not Medicaid. We found that nationwide, perinatal mood and anxiety disorder diagnoses among privately insured individuals increased 93%, or almost doubled, in the period between 2008 and 2020. However, these diagnoses grew faster in 2015 to 2020 after the implementation of the Affordable Care Act than it did in the period before the Affordable Care Act from 2008 to 2014. And most states and demographic subgroups experienced increases. So on this map, the darker colors represent a higher level of increase. Next slide, please. So the Affordable Care Act helped more people access care, including treatment for mental health conditions. We looked at how many people received a diagnosis. Of the people who received a diagnosis, how many received a psychotherapy visit? And again, we found that the rate of psychotherapy increased over the whole period and rose faster after implementation. And that's where you see the two lines, the break. The second one on the right-hand side showed a sharper increase. Next slide, please. However, here, although rates of suicidality increased over the entire period we studied, as you can see, before the ACA, the rates were rising, but actually afterward, diagnosis rates were decreasing. So that is an encouraging sign. Next slide, please. Our team is also working on another project in collaboration with a variety of advocacy groups and experts in the perinatal mental health field. Many of these groups and experts told us that there's simply not enough information about perinatal mental health. And so without good information, it's hard to make change. So in response, our team is putting together data about perinatal people with private insurance shown here and ultimately public insurance. And we're putting this information into dashboards, maps, figures, and tables that anyone can see. And so as you see here, what these changes that you're seeing is that each click or each color represents a different year, or they will over time as we develop these dashboards. And so not only are we looking nationally, but we're looking by state. And there'll be a number of different subgroups that you can look at. And when you go to the web page, when it becomes live, you can click in on them and see actual numbers by state. So we're hoping to have that ready quite soon. This is just one example, and we hope to have this ready soon. So now moving to policy implications. So gathering information about perinatal mental health, such as through these studies, the Dashboard Project, they help us generate data, which helps us create good maternal mental health policy recommendations. So here we've listed a few, which include evidence-based screening guidelines, initiatives to increase access to treatment, tailored interventions to address racial disparities and other gaps, and then specifically focusing on culturally sensitive care to close disparities. Next slide, please. So this is the final slide for my presentation. And for our team, we continue to focusing on, our data-informed policy evaluations, providing recommendations in scientific journals and other publications, sharing data with politicians and advocacy groups, and talking about our findings in presentations to the scientific community and the public and families, just like this one today. We were honored, and I was honestly personally very excited to have a chance to meet our governor, Gretchen Whitmer, when we were asked to present last year at the National Governors Association Roundtable in Detroit that was focused on youth and maternal mental health access and affordability. So again, policy informs clinical practice, which also helps shape patient experience. So now I'm going to turn over the floor to Dr. Maria Music, who offers the clinical perspective next, as she will share her experiences as a perinatal psychiatrist. Thank you.
Good evening, everyone. Thank you for having me as well. And I'm happy to bring this next perspective, the clinical perspective. And I want to kick it off with kind of, first setting the stage. What is happening in pregnancy and postpartum? Well, to sum it up, everything is changing. Everything is different. And I just want to center this in first the bodily changes. With the pregnancy, body volume, blood volume, fluid volume increases, and that has consequences to the shape, but also the well-being and the ability to move and to kind of go on with life. And it also has consequences to any medications that maybe were used for pre-existing conditions. They are more distributed in the volume and their levels drop. And so that's important too. That might have consequences to health. Similarly, our gastrointestinal tract, our digestion changes. And so women experience a lot of, symptoms from nausea, vomiting, constipation that impacts well-being, but also impacts again, absorption of nutrients as well as medicines that maybe are used for pre-existing conditions. I want to highlight the slide on the right panel, just to show that all these hormones that are floating through the body, like progesterone and estrogen, just to look at the first two graphs, that across the pregnancy, these levels rise, and with the birth, there is a massive drop within hours of all these hormones. And we know in well-being and mental health that this rapid change of all the hormones floating through the body is a major destabilization. Women call it, this is my emotional roller coaster. And we even have a name for it. It's called the blues. So the blues just throws everything off, and it starts already at the end of pregnancy and continues into postpartum. So lots of changes. Next slide. Another big change that I want to highlight is the change to sleep. Sleep is our best well-being protector. A good night's sleep gives you, restitutes your energy and your well-being. And as you can see on the left panel, Across pregnancy, there are zillions of reasons why women don't sleep well. And that is from waking up frequently because you have to urinate, or because you're feeling uncomfortable, or because you're larger and you can't move. Many, many reasons. But all of them are important. And on the right panel, you see what's the frequency of normative, we call it insomnia, which means another word for I can't sleep, I'm not sleeping well. Well, 60% of women say I can't sleep, and that's from pregnancy to up to 2 years, like definitely 1 year postpartum, several months postpartum, and only by 2 years postpartum, it drops to 40%. So sleep is disrupted. The body is changed, sleep is disrupted, the hormones are changed. All of this is setting also the biology up for vulnerability. Next slide. So with that said, next slide, Amy. The sleep disruption, fragmented sleep, and being always on with the baby, all of this translates into the next slide, is that actually being depressed in postpartum, when we look at data from pregnancy across the first year postpartum, having some sense of depression or having the symptoms of depression is almost, I wouldn't say normative, but it's super common. 10 to 20% of women experience depression. That's the blue line. You can see it's kind of stably chronic across postpartum. It starts to recover at the end of the first year. And if you take major depression, so that's severe depression, it's around the 5% mark the whole time. This is old data, but still, it's similarly valid. Next slide. The issue is that depression has many, many symptoms. And I just want to walk through some of those symptoms with you to remind ourselves, what does depression look like? When we diagnose in psychiatric terms, we say you have to have at least 5 of those. And 2 of those have to be the first 2. You have depressed or irritable mood. It's more often common that actually to be more irritable and edgy than sad, or feeling numb and empty. And then you have to lose joy or interest in things that commonly bring you joy. And that could include being a mom, caring for your baby, or being excited about the pregnancy. And then you see that you have a long list of different symptoms. Depression is really looking multimodal. You can sleep too little or too much and oversleep and retreat to bed and withdraw to bed and not wanting to get up. You can eat too little and lose weight, or you can overeat and comfort eat and gain a lot of weight. You have excessive guilt. You can be tormented and self-blame, feel bad about yourself as a mom, feel like a burden. Unable to concentrate, not having energy, not moving, either moving very slowly or moving very agitated and being very anxious, feeling trapped, hopeless, feeling chronically anxious, worrying, ruminating about things. And one symptom is feeling there is no other way out. I just want to sleep off forever. I want to be gone. I feel such a burden that I don't want to be here, and I want to end my life. So that's the suicidality symptom, and it's one feature of being depressed. Next slide. Often depression doesn't come alone. In fact, I would say, I'm doing this now 30 some years. Mostly, depression is not a standalone illness. It particularly in contexts of multiple risks that are, again, very common, like trauma, past or current, violence exposure, losses, separations, loneliness, low social support, financial, housing, food insecurities, childcare challenges. I mean, you name it. In a stressed community, depression is often co-occurring with other illnesses. And we call all these factors, these risk factors, the social determinants of health. Well, in the context of these social determinants of health, depression goes along with anxiety that can be more generalized or more trauma triggered, like post-traumatic stress disorder. And then often the overlap is 60% minimum, 60 to 80% of all of these is that there is self-medicating with substances, either prescribed or obtained, not from prescriptions, but bought on the street. Next slide. In terms of suicidal ideation, they're actually super common, right? This is a symptom of depression. And there's a fluctuating nature of suicidal thoughts. And a person might go back and forth between more passive suicidal thoughts and more active. Let me tell you what a passive suicidal thought is. That might be the thought that pops into your mind once in a while when you feel stressed or kind of feeling hopeless, that you feel like my family would be better off without me. I'm such a burden. And it's the thought of life is not worth living. I have a desire, death would be a potential solution and a way out. It's almost comforting for my patients to think about suicide as a comfort. But the patient then recognizes and can get rid of these thoughts by distracting themselves or calling a friend or doing some activity that is semi-enjoyable. So that's more passive. But over time, if the illness progresses and somebody gets more and more depressed and more symptoms occur, this passive suicidal thought becomes more active. And that might be a thought like, okay, I can actually do this. I could take the pills, or I could, run into the street or drive my car into the ditch, and I could do it right now. And I have means, I'm thinking about it, how to do it. So the thoughts become more concrete, there's an intent, and they become more intrusive. And it's harder to disengage yourself from these thoughts. And we call them, they kind of stick. And that's the danger, right? That's the step to an action. And so between active and passive, people fluctuate, and it's really important to kind of get a good assessment. Next slide. So when is then from an active suicidal thought to the action, the attempt, and then the completion, there are clear risk factors that are making this more likely. And we already heard this from Dr. Mezuk. Who are the persons who then, in the context of being depressed, are actually then moving from passive to active to action? And it's persons who have a constellation of risk factors, which includes trauma, traumatic contextual environment, maybe childhood trauma, history of self-medication with substances, violence in the home, prior attempts. Once you crossed the threshold to action, you are actually more likely to cross it again. So this constellation of risk factors is really important to think about, because that might move you more from passive to active to action. Next slide. And so I want you to think about the numbers. When we think that 1 in 5 women experience depression, 1 in 5 of those with untreated depression is at risk for suicide. It's like 20% of those who experience depression are also having suicidal ideation. In pregnancy, we think the rates are between, the 10 to 20%, also suicidality. In postpartum, it's a little bit lower. we can think about that. But if you translate this into, if you have 30 people, pregnant or postpartum, in a room, 6 of those will be at risk for depression, and 1 of them at risk for suicide. That's a huge number. Next slide. So we heard about this, that the maternal mortality in the United States, which is higher than any other mortality rate in the Western industrialized countries. In the US, it's 22, 25 per 100,000. In all other European countries, it is 5 to 6 per 100,000. And it's unequally distributed in this country as well. Black African American women, it's 45 per 100,000, whereas white Caucasian women, it's 13 per 100,000. So, but of those deaths, 20% is due to maternal suicide, making this very common. Next slide. This is really important. That's why we're talking about it tonight. But we need to also talk about resilience, because you can heal. There's hope, and healing is possible, but with help and with the inner resources and outer resources, and just kind of walk through some of these resiliency factors. Amy, if you could just kind of click and as we go. So of course, a social network that is strong is important. Being involved in the community, having a community, takes a village to raise a child and be pregnant. And as we know by Dr. Murdy, the Surgeon General in the United States, talks about loneliness. We have an epidemic of loneliness in the last Surgeon General report. So that's important. But then also inner resource like spirituality, your own core beliefs are very important. Next slide. Stable housing, financial security, that's the basic. Access to mental health, that's what Dr. Zivin was pointing to. We have to have access to health, otherwise, how would you even access resources? Your own experience of overcoming adversity in the past is very important, because that is building your own resilience. Education, awareness, that's why we do what we do tonight. Coping skills, self-efficacy, which is access to therapy, where you can learn these skills. Next. Healthy lifestyle. Sleep, that means sleep, access to food, access to stable, living conditions. And then, next. I think a very important one is connecting and learning from others with similar experiences who have overcome adversity, who have battled and struggled and were challenged by suicidal thoughts and depression and mental health issues, and can teach us about their journey of healing. Next slide. I want to center this and contextualize this in actually a phenomenon that is researched on and known about, and it's called the Papageno effect. You might know it's a famous opera by Mozart, my landsman from Austria, who wrote the Magic Flute. And in there is a character, Papageno, who plays the magic flute and contemplates suicide during one of the scenes. And then there are these spirits who come to kind of help Papageno to think about like non-suicidal alternatives, what it is worth to live for. And that is actually really very important, because this Papageno effect describes the protective effect of hearing stories and sharing stories about suicidality and showing hope, healing, and non-suicidal resolutions. And research shows that this is very protective and can be used also widely when we talk, and should be used when we cover suicidality in the media, to talk about it in a way that keeps not sensationalism, but creates hope. So with that, this is my last slide. I actually want to contextualize that this is also why it's so powerful that we have Carla, um, who graciously agreed to share her story, an inspirational story of hope and recovery, with us about her journey with suicidality. And so I want to introduce Carla. Carla is a Mexican American woman, first generation college graduate, mother of 2 young children. And she shared with us a recording of her lived experience with suicidality. So, Amy, if you would be so kind.
I have struggled with suicidal thoughts and anxiety, I would say about my whole life. Probably around 8 or 9 years old is when I remember feeling that way for the first time. I grew up with a pretty rough family life. There was a lot of chaos, abuse, and just trauma. And this may have also contributed to some of the issues that I had as an adult. Now, when my children were almost 3 and my youngest one was still a little baby, not even 1, I experienced some pretty traumatic stuff. Within a short amount of time, I lost my grandparents to a very tragic and violent death. And I had also split with the father of my children, who I was in a very toxic and abusive relationship with for a few years now at this point. I decided to go back to therapy. I was really worried about being judged. I felt so much shame around who I was as a mom and whether I was even a good mom. And I actually formed a really good working relationship with one of these therapists that I was engaged with. My children's father ended up making a physical violence threat against my therapist, and I was discharged from their care. This was devastating for me. It felt like I had lost the most important people for me in my life at the time. I felt alone. I felt distraught. I felt vulnerable, and I convinced myself that I wasn't a good mom and that my children were better off without me. Well, the children were with their dad, my ex. These thoughts just wouldn't disappear. They just kept coming back, and I couldn't ignore them any longer. So I decided to attempt suicide. Now, after this had happened, I was able to receive some stabilization and help at the hospital, and I did go into inpatient care for about a week. Now, after this, I was still in therapy, and I found a new therapist as well. I still continue to struggle with chronic thoughts of suicide and despair. It wasn't as pressing, they weren't as intense, but these thoughts were still there. I was still pretty miserable. During this time, my substance use was getting to a very dangerous point. Anytime that my children would be at their dad's house, I would take the opportunity to get high, to use substances to try to numb out the pain, try to not feel, I would say. Now, I continued with therapy, and during this time, I decided that I needed to be vulnerable, that I needed to lean on my therapist for support, and I was able to kind of take down some of that anxiety and share more openly. During this time, since my substance use was increasing, there were several times where I just was not okay. The weekend ended and my children were supposed to be coming back to me, and I was still not okay. I was still experiencing a lot of the effects of substance use over 3 days of no food and no water and no sleep. Now after this, I did decide to go into an intensive outpatient substance use program. This was really helpful for me. I think I was there for about 4 to 6 weeks. Not really quite sure. But I was able to express my pain, and I was able to be around other people that were also feeling this level of desperation, enough to be using these substances. Now, I continue to have a lot of dark moments. I continue to having to share embarrassing and shameful things with my therapist. I was convinced that they thought that I was a bad mom, and that they could see that I was failing as a parent or as a human even. But I was consistently met with empathy and compassion and care, and it was something very different for me that I hadn't experienced. So slowly the dark and intrusive thoughts weren't happening so often. Things were getting a little bit better. I continued my work in therapy. I actually had 2 different therapists, one for me and the children, and then an individual therapist for myself. Now, flash forward to today. My children are now 4 and 6. I haven't had any suicidal thoughts or felt really anything close to the level of desperation and pain that I felt just a few years ago. I actually think that for the first time in my life, things are going okay, and I can say that with certainty. I finished graduate school, and I earned my master's of social work. I am now working as a therapist for young children, and it's beautiful to see how I can help other people, and I can relate so much to clients just knowing how painful life can really get, and how the level of desperation that keeps you in the darkest, shadiest moments is not forever. And I hope that I can use that in some way to better understand my clients. I have not used substances to self-medicate. It's been about 3 years, and my mind is clear. I think deeply. I feel deeply. I wake up every day, not necessarily beaming with happiness and sunshine, but I wake up every day feeling compassion, feeling love, and feeling hope for myself. I often think to myself how 10 years ago, and even more recently, I had felt hopeless. I struggled with my self-esteem. I had imagined that life would always be this way. I remembered what I felt when I was suicidal. I would use escape fantasies, or I would use substances to try to numb the pain out. Now I have many reasons to live. I can honestly say I'm happy. And I hope that if anyone else is dealing with suicidal thoughts, especially moms or parents, that you know that there's so many people that feel the way you have felt, and that your pain is unimaginable, but that we want you here.
Unmute. Hello? Yeah. Can you hear me? Can you hear me? So thank you to Carla for sharing her story here. The story that showcases the emotional struggles when going through depression and experiencing suicidal thoughts. I think that her story showcases the depth and severity of suicidal thoughts that can even lead to a suicide attempt. And we are so glad that Carla got help and is with us here. Her story just shows her incredible resilience to utilize the supports and resources that she got and sought out to, and to overcome her mental illness and the suicidality. It's really inspirational and gives hope. And so her story shows how medical care and therapy can be helpful to get help with those emotional pains and suicidality. And in this spirit, I want to share now these resources with you, both regionally and nationally. Please use them. It's really very important to take that step, even if you feel it's maybe not helping, but it will. I think that her story shows that. We have the National Maternal Mental Health Hotline, a wonderful resource, 24/7, reaching out. They know about maternal mental health and suicidality. We have the 988 Suicide and Crisis Lifeline. That's more a general number, but also is there for you 24/7. Postpartum Support International is a wonderful resource. It's actually started by a family member now 25 years ago who lost a sister to suicide. That is the peer support group that is now nationally and internationally, has chapters in every state and provides amazing work. Not only a PSI helpline that is 24/7, but also support groups every day, 4 or 5 free of charge support groups. So please use that, PSI International. We at the University of Michigan Psychiatry Emergency Services are there 24/7 for you with a crisis phone line. My own service, the University of Michigan Perinatal and Reproductive Psychiatry Clinic, is available during the week, is available to see patients virtually or in person for mental health care. We are there to reach out and support comprehensively with therapy and medication management. And then I want to highlight MC3 Perinatal, which I'm also the director of, which is a state-funded, Michigan Department of Health and Human Services funded resource that not only educates every provider, like obstetrician, family doctor, nurse practitioner, midwife, about mental health, and is basically a on-the-spot lifeline for these providers to get some services and recommendations of safe medication management, for example. But also there is an arm where moms, women, family members can reach out themselves by accessing this QR code and access instant, immediate help. If you experience any of these symptoms of mental health issues, feeling overwhelmed, stressed, exhausted, or suicidal, this is the place for you to get instant access to help, to get therapy, to get connected to other providers, to other services, whatever it takes to help overcome this illness. So these are the resources. And I once again want to thank all of you. We are now at the end of our presentations. I want to thank the speakers, and I want to invite your questions and comments. And we, the speakers, and Carla, who is actually in the webinar and didn't want to be on camera, but might be available for questions, we are here to answer any of the questions you might have. So thanks for being here tonight.
Right, wonderful. Thank you to Dr. Mezek, Zivin, and Music for that presentation. I really enjoyed it. I will be going into our Q&A portion now. So if anybody has questions for our panelists today, please go ahead and put them in the Q&A box. One good one that came in that I thought we could start with, what resources are lacking and how can the community get involved to create change?
Maria, I think you probably have the best sight line on that just from your clinical work.
Well, thank you. I'm happy to take the first. I think that the two aspects in my mind. One is what we are doing right now. Awareness and non-shaming, non-stigmatizing discussions about suicidality. As I try to say, suicidality is a symptom of a larger condition called depression that a lot of women have. And that is partially understandable because there are so many changes in the body and the mind at this time of pregnancy and peripartum. So just having awareness and talking about it and feeling like I can share this, that I'm experiencing this. This doesn't mean that I am a bad person, a weak person, a bad mom, or feeling shamed and ostracized by society or your family or your friends. That's number one. So having this discussion and raising awareness that it's okay to talk about it. That's number one. But just talking is not enough. The second piece is if I now share and talk, I need a responsive community that can give me help. And that means access to help, instant access. That's why we do MC3. That's why I believe in it. You have to have immediate access to help that is competent, safe, and appropriate. And that means also what Bree and Dr. Mezuk and Dr. Zivin were talking about. I have to put systems in place that finance this access to help. There's no use in having a great psychiatric system when there is a wait list or there is no funding and I can't access it. So we need awareness, no stigma, not blaming people that they are weak because they have depression, suicidality. The language of blame is absolutely inappropriate. But then we also need to create systems where people can get help when they need them immediately, not a year from now. So that's my brief answer.
Well, and it gave me just a chance to think back again from my system level perspective. And you started to highlight this, that one thing to recognize is that there's, and this is not just true for perinatal mental health, but there's a mental health care provider shortage nationwide and in many regions, which is part of why the MC3 and other programs began to exist, because even prior to the pandemic, if there was absolutely no mental health providers anywhere within, say 100 miles or whatever where you lived, it didn't, that wasn't going to help. And so, having the opportunities now for telemental health, it can be useful, and not just for travel reasons, but also for things like if you don't have childcare or, you don't have time to travel, all of those things. And yet, one of the things I've studied with my group when we've published other papers on is, in one sense, it's wonderful to have better access in terms of better insurance coverage or lower co-pays, but having more people be able to access care doesn't change the number of mental health providers that exist. So what happens is there are more people trying to get care and people are getting fewer total visits because of a capacity issue. So there's that issue. Another area to mention that we haven't talked about a lot yet is integrated care. So, having mental health professionals talk to your OBGYN or to your primary care physician. Too often, everybody's operating in their own clinical practice, and yet, having them be able to talk amongst each other and know, what is needed and how best to treat is important. And then another area that is still really ripe for development is what is called like mother and baby units for individuals who have mental health conditions. So for some people, if, typically if you have to have a mental health hospitalization during or after pregnancy, I guess after delivery, you're separated from your baby, which is, not necessarily helpful. And there are a few places in the United States that have this kind of care, but very few. And yet this has, been around for decades in other countries, ranging from the UK to India. So why are we so behind on this in the US when we know that it can be better for both mothers and their infants to stay connected even while mothers are struggling? So those are a few other areas that I think about.
I would echo everything that Dr. Music and Dr. Zivin said, and add, I think the other element this was illustrated with Carla's experience as well, is that depression is occurring often in the context either of a trauma or substance use, both of which have complicated other types of systems that people often encounter with. So that might be social services, for example, in a situation of, or the police, for example, in the situation of intimate partner violence, or the legal system in the sense of if this person is using illicit substances. And both of those systems don't necessarily have a therapeutic lens in terms of how they would approach this. And I think like there are wonderful examples. We are fortunate here in Washtenaw County to have therapeutic courts, so drug courts and mental health courts, which do understand that if somebody's experiencing depression or post-traumatic stress disorder or bipolar disorder, whatever the case may be, that they are more likely to be engaging in illicit substance use, and that addressing both of those conditions at the same time is essential to this person's overall wellness, but also just, every system has to be on the same page in terms of you can't sort of be willing to disclose your substance use to your OBGYN and fear that they're going to call social services on you, for example, right? So like everyone sort of needs to have this therapeutic lens in order for mothers and babies to be able to move through this, as Carla's example illustrates.
Great. I think if we can continue at this kind of system level view, we had another question come in on policy, so probably for Kara. What is one key takeaway that lawmakers should consider while making new policy or policy updates in this domain?
Well, as a policy researcher, I always think about intended and unintended consequences of any policy. So often, sometimes, something that can help in certain circumstances makes things more difficult in others. Or policies may not necessarily be helpful. For example, we were talking about, again, people getting potentially better coverage through, say, the Affordable Care Act. But if the real issue is stigma, it doesn't matter, for example, if everybody had free care, let's say, right? Because if you feel uncomfortable or unsafe, talking about a mental health condition, then it's not about cost, right? For example. And so I think it's trying to have tailored policies. However, one of the things we say about, many policies, including Medicaid coverage, is that if you've seen one state, you've seen one state. There's so many differences by state about everything from mandated screening to length of insurance coverage postpartum and Medicaid to, rates of copays, to available insurance policies. So, you can get into a whole complex web. And, another thing that we're looking at that we haven't talked about much today, but just to have on people's minds potentially is, with changes in access to reproductive health care, that also lends a whole other layer to potential mental health conditions, which again, we don't normally think about, but thinking about mental health through the whole context of pregnancy and potential pregnancy outcomes, how do policies affect mental health? So those are a few examples. Fortunately, there is increasing attention to these issues. So not just the Affordable Care Act, let's say, but there's something called the White House Blueprint that came out that was talking about highlighting more attention for maternal mental health conditions and putting resources into place. Some other federal agencies have also been drawing attention to this work, including providing reports to Congress. So that is the fortunate component, is that I think, even in the last decade or more, there's been a lot of movement around policy and treatment.
I've had a few questions come in kind of in the same area at more the individual level. So we talked a bit about some risk factors for suicidality and postpartum depression. And I think people would be interested to know, what can people do if they have known risks? So what can childbearing people do to kind of preemptively help mitigate their risk? And then questions too from providers about if they're aware of risk factors in their patients, kind of what can they do ahead of time to help minimize symptoms or get help?
Maybe I kick it off I think knowledge is power. I tell all my patients, the more you understand yourself and the context in which you live, your outer and inner resources, and challenges, the more you can devise a plan together with your provider, a trusted provider, how to tackle it. I mean, that's kind of like in life where you know what is the circumstances that I'm dealing with, and I can now create a strategy how to overcome this challenge. So if I, for example, I have patients who come to me and say, I have pre-existing condition. I have had bipolar illness my whole life, and now I'm pregnant and I'm worried. Am I going to get, symptomatic? I don't want to take my medicine. Do I have to? I feel hesitant about it. Can we talk about it? What else can I do in my life to kind of minimize my risk for decompensation? Well, then we talk about what does your life look like? What else is in the mix of your stressors, partnerships, your social environment, your network, your financial, your resources? How can we buffer you with resources that are available that we find together, that I help you well? That's why we have social work and counseling on board in our clinics, in our systems, to really package an individualized plan for each person's own journey through pregnancy and postpartum. I work with a lot of persons, birthing persons, who have a stack of these risk factors: past trauma, current adversity, substance use, in recovery, mental health issues, comorbid illnesses. I can promise you that if you trust, or hopefully you can build trust to a provider who listens to you and who helps you find resources that you can overcome and mitigate this risk. There is no risk-free journey. Of course, there might still be some symptoms and there might be some, challenge, but tackling it together with a provider, with someone who is there for you, whether that's through MC3 or the perinatal clinic or a helpline or your family, and then you loop someone in, or your primary care physician who you trust. Speak about it, loop people in early. I think that's my message.
I would only add that this is not based on data, but from my own experience as a mom, is I just want to echo the idea of having a trusted healthcare provider. When I was pregnant with my son, I had a change with I changed my OB/GYN, and at some point I sort of felt like that this wasn't the right person that I wanted to. We didn't see eye to eye on things, and I'd never left a doctor before. That seemed terrifying. How could I possibly do that? And I ended up moving into a program that was group prenatal care, where I was met my anyway, my sessions were with other pregnant people who were going, at the same stage in pregnancy as I was. And I didn't think that's what I was going to like going in ahead of time, but I figured why not? This was the recommendation when I was sort of breaking up with my OBGYN. And it really was helpful for me. And I don't know if studies have looked at yet, like to what degree these kind of group prenatal visits, which again, we're not based on any specific risk factors or anything like that, but just the fact that we were all going through the same life-changing event as Dr. Music showed, all the hormones, and that's what we call a regression discontinuity in my neck of the woods. But I also want to echo, because there is a mental health provider shortage. I want to echo some of the efforts that people. So we all, when we talk about suicide prevention, I also like to rephrase this or frame it also as mental health promotion, and that we all have an ability and frankly like obligation, I think, to like leave people better than than they were when we first encountered them. And so, this might be a doula for some people. This might be a church group for some people. This might be if your employer has an employee assistance program, because if you're going to be going on maternity or paternal leave, or et cetera. Like, so I definitely want to encourage sort of know that there's a lot of different ways to build the support. And I think the kind of puzzle illustration that Dr. Music showed us was really helpful in thinking through that, because it is the case that because of the behavioral health workforce shortages, you might need to knock on a few doors potentially. I mean, obviously the MC3 program is a very important and critical program, but I also want to just emphasize that there's lots of different ways to build it. If you don't feel comfortable talking to a therapist or a psychiatrist, that there are other people that you should build that community around. I think that's sort of the main point, is like there's lots of different ways for that support and trust to be built.
I just want to amplify what you just said, Dr. Mesic, because that's actually the point that I was trying to also make, is we know that connectedness to others, where I feel seen, heard, and I can trust, and I feel appreciated and nurtured in a relationship with others. We are social beings as humans. That is actually healing. And so early on in your journey, connecting to others, and I like that you suggested, whoever that is, other birthing persons, like centering. We have data that group care is better than individual care. Absolutely. It's just logistically harder to do, and that's why the system doesn't want it. But we know that group peer-to-peer support is super helpful. We know that, just having a telephone chat with someone who over time you build relationship, or your church group, or your mom's walking group, postpartum, all of this is helpful. Early enough, the important piece is to utilize this early. The problem often is that because depression has that symptom that you withdraw more and more and more, the more depressed you get, the more you withdraw. And that's where you basically are getting deeper and deeper into the illness and less accessible for any helpers. So early on, reaching out, planning it out, I think that's the helpful, or that's a key. So I'm just amplifying what you said.
Let's talk a bit more about those helpers, support people. One question that came in was, do you have advice for those who are supporting someone close to them who is currently pregnant and has attempted suicide in the past?
Well, maybe again, I give it the first kind of round of, I mean, that's a tricky situation. I can see how that might feel scary and challenging for both the helper and the person who is affected, because here you have this this worry, is this experience of deep anguish and despair, is this going to come back with all those hormonal changes and sleep deprivation and all the is maybe this depression and again suicidality re-emerging. So having discussions about this early on might be an important piece, not trying to forget and say, well, it's not going to happen, but instead saying, well, I had this experience once in my life for whatever circumstances and for whatever reasons. It could be because there was a trigger, a stressor, or because there is a biological vulnerability. Depression is also a biologically passed on condition. But having that awareness that there is this vulnerability, and then building around it layers of protection and discussions. So as the person who is the helper, I would encourage the potentially affected person to talk about it and to talk about what is your own anxiety that this comes back, and what could we do, how would we approach it if you start feeling worse, what were your red flag symptoms last time? Oh, I stopped sleeping, I started withdrawing, I started not caring for myself. Well, if that comes back, is it okay if I notice and then I talk with you about it, and then you and I go and get help together? I bring you, so having a lot of like anticipatory discussions, and absolutely doing other self-help kind of educational things like listening to podcasts or reading education materials. But I think that the conversation is and connection with another person is always very helpful. Dr. Masuch, do you want to elaborate additionally, or?
No. I just wanted to share this. I love different podcasts. This one's not specifically about suicidality, but about just whether it's loss. So people have lost a child, lost a partner. A lot of people have been through some sort of health crisis. The interviewer themselves has advanced colorectal cancer, and as somebody with a history of that myself, I was particularly interested in learning about her story. But also, she's also a professor at Duke Divinity School, so she kind of also has an interesting or integration of her spiritual history and understanding of the world as it relates to these terrible things that also happen in the world. And so I found it to be really a way to engage in or listen to people's stories from in a way that really centers the resilience that those experiences can build. And so yeah, just to put it out there. And she's hilarious. So I mean, it might be some gallows humor sometimes, but it's still very funny.
Dr. Music, you mentioned kind of having a care plan in place for people who have a history of perinatal mental health or just mental health concerns in general as a known risk factor. Somebody asked, do people usually recognize when they are in the midst of possible postpartum depression?
Well, actually, I would say yes. I think that persons after the birth experience a lot of emotional stuff, right? And as I talked about, the first couple of weeks, usually we say the first 2 weeks, it's a roller coaster. And that's what we call the blues. It's because the hormones are all, recovering from that rapid drop, and you just went through a birthing experience, which could have been hours or, long or short, but it was painful, and there were medicines involved maybe, and there was sleep deprivation involved, and you are trying to figure out how to breastfeed or how to feed, whether you choose bottle or breast. All of this creates an emotional roller coaster, and persons experience crying, laughing, anxiety, not sleeping, being irritable, and being all over the place. That's the blues. That lasts 2 weeks, and then it starts to quiet down. However, some people already went from the pregnant, when they already in pregnancy had some sadness that was bordering depression, very anxiety. This blues is just exaggerated. Or let's say they were fine in pregnancy, but then the blues subsides, and around week 3, 4, 5, they start to kind of go downhill. And you notice, I am not enjoying myself. I am having ongoing, with kind of fatigue, and I'm withdrawing, and I'm just not enjoying the baby. I don't want to be around the baby. I don't feel joy. I don't feel interest. I feel sad. I'm emotional. I am not sleeping well. Well, sleeping, nobody sleeps well postpartum. That takes at least 4 to 6 months. But kind of these symptoms of not feeling right, women notice that. Often also family members notice that. And then usually around the 4 to 6 week postpartum visit, these persons might share it with their OB provider and say, I don't know, I'm not feeling right. And that's often where the provider might start a discussion about depression, do a screening. We have these standardized screeners. One is called the Edinburgh Postnatal Depression Scale, or EPDS. If somebody wants to Google this, there is self-ratings you could take. It's called EPDS. And if you score threes on several of these questions, yeah, you might be struggling. You might be sliding into a depression. And that's the reason to then reach out either to a trusted person, or your doctor, or a nurse, or your family member, and say, let's get me some help.
Right. So we definitely want to be talking about this, reducing stigma, supporting people in our community. So one question that came up was, how can I talk about postpartum depression with others to support awareness?
My, just to begin with, I think it's important that we sort of understand that the person has depression, that like it's not who the person is, but rather that's, just like somebody might have diabetes or have cancer, they can have depression. And that it's important, I think, to, understand that depression, as Dr. Zivin, showed, the majority of people with depression don't get timely treatment. And, that, as we've talked about with so, I think what I guess I would sort of encourage is, what I'm trying to say is encouraging empathy, because I think sometimes, while we may want to, in the rush to help, or in the desire to kind of want to help this person, we may have ideas or want to share things that they could, or we might even phrase it as should be doing, like, should you go for a walk, should the, et cetera, et cetera. And I think part of what being an empathetic listener and sort of supporter is being able to just listen to whatever this person needs to share with you, or sort of making it clear that you're available to them to share, and also celebrating when things go well, even when it's, might seem like something small, for example. So, because I think that when you're in a depression, it's really difficult. There is no logic to the depression. And so it's not like the folks don't know, oh yes, it might be better to leave my bed for the first time in a few days, right? But it's not like that. It's not a lack of knowledge per se, but it's literally like depression is not just in the brain, it's in the body, and that's true not just when somebody is pregnant or recently pregnant, but just the entire illness. And so I think being able to understand to be there empathetically, to use words, I mean, when we do our suicide, for example, intervention training, we are taught to ask the question, like, are you feeling suicidal? Do you feel like you might, that this is something you're thinking about, to use those words? Because it also it can feel very difficult to ask that directly, but the question, persuade, refer training that many of us go through as part of our jobs. I mean, I'm a professor, I'm not a clinician, but as part of my job, part of what I do is I encounter students, for example, who may be dealing with mental health challenges. And so it's important for me to understand what is evidence-based, what does that mean to be able to support people through difficult challenges. And so I guess I would sort of say that, like, using the words echoing the words back that the person is saying, if they're saying depressed, if they're saying, like that's very helpful. And then not trying to fix it per se, but being able to be empathetic and stand with them in the same way that you would if somebody was dealing with a physical illness is my advice that I would give here.
Great. Thank you for that. That was a great way to end the seminar, I think, on a hopeful note of supporting other people. So we're right at a couple minutes past 8:30. So thank you to all of our attendants today. I am happy to see so many people joining to talk about this issue. Please take a moment to reach out to a parent in your life today. Ask them how they're doing, see how you can support them. But thank you again to all of our panelists today, to Dr. Music, Dr. Mezek, Dr. Zivin, and to Carla for sharing her story. And yeah, thank you all for being here.
Thank you, Amy.
Thank you, Amy. That was wonderful.
Good night, everyone.